Hello, everybody. I'm back. Dr. K. Agarwal, President, Heart Care Foundation of India and Confederation of Medical Association of Asia and Oceania. And you are watching Med Talks with Dr. K. Agarwal, 7 p.m. show, 72nd episode, and in total 773 various programs on COVID-19. Basic aim: remove the fear of COVID-19 from the mind of the people. Let's have the headlines of the day. 7.1% of the adults were exposed to COVID-19 by the end of August, says India's second national sero survey. The initial one was less than 1%. That means 7.7% of the society in the whole country has already been exposed to the virus. The number is much higher in Delhi, in Pune, in Bombay, in Indore, but the national average is 7%. The Moderna COVID-19 vaccine appears safe and shows signs of working in older adults, as per a study in New England Journal of Medicine. Serum Institute of India will make up to 200 million COVID-19 vaccines available for many countries with the help of Bill and Melinda Gates Foundation and Gavi. Teicoplanin, an antibiotic, could be a potential medicine for COVID-19, says IIT Delhi research. Let's go to the topic of the day. High blood pressure, hypertension, 25% to 30% of the society has it. Maybe during lockdown, the incidence may have gone down. But as on today, too many guidelines are spoiling the broth. To discuss about this, I have a special guest with me, Dr. Soumitra Kumar, Professor and HOD, Department of Cardiology at Vivekananda Institute of Medical Sciences, Chief Coordinator, Academic Services Cardiology at Rabindranath Tagore International Institute of Cardiac Sciences, and a consultant cardiologist at Fortis Hospital, Kolkata. He is the past Honorary Secretary of Cardiological Society of India, President of Indian Academy of Echocardiography, President of West Bengal Academy of Echocardiography, and a fellow of many societies, both national and international. Welcome, Dr. Soumitra, to be here in our show. This show,
Thank you, Dr. Agarwal.
In this show, we will be live in many platforms, and we expect at least 10,000 people watching you in the next couple of days in total. And
It's
the
a pleasure
topic
to be
is,
here.
thank you. So let's listen from you something. If you have some slides to share, little bit
Yeah,
introduction
I have.
before we start our
Yeah,
question answer.
just to. Can I have the slides, please? Yeah. So, good evening, ladies and gentlemen, and very good evening to you, Dr. Agarwal. Also, thank you very much for the invitation to this very popular program. So, I'm going to show you some very relevant slides pertaining to hypertension in 2020. Next, please. So, the global prevalence of hypertension is around, you can say, on an average 30%. In some countries, you can see it is above 30%. I mean, 37 is the highest. Some countries it is little lower, but if you look at the average, it is more or less 30%. So one in three adults have hypertension. So you can imagine the total of number of hypertensives all around the globe, a huge problem. And in fact, as we have learned from the several publications, including the one that came up in Lancet about a decade back, that it is the number one global killer in the world, high blood pressure. Next, please. And when it comes to India, the prevalence is almost the same. I mean, there is still the little urban-rural divide. I mean, little higher in the urban population than in the rural population. But unfortunately, the rural population is catching up fast. So what we apprehend is that very soon there will be no discrepancy in terms of prevalence between the urban and the rural population. And hypertension, as you know, is the biggest cause or the most important cause of ischemic heart disease, heart failure, stroke, and chronic kidney disease. An estimated of 54%, 57% of stroke and 24% of coronary artery related deaths can be attributed to hypertension. So, given the huge population of India, you can also make out what is the problem related to hypertension in this country is. And in fact, like the diabetes, India is also dubbed as the hypertension capital of the world. Next, please. So the topic of the evening is that too many guidelines, is it spoiling the broth? I mean, apparently yes, because when you have too many guidelines, that means that probably there is no consensus globally, and it really confuses the people. So here you can see the biggest of them, the ACC-AHA, which came up in 2017. Then you have the ESC and European Society of Hypertension guidelines came up in 2018. We have the NICE guidelines, which came in 2019. And the latest of them has been the International Society of Hypertension guidelines, which has just come a little, I mean, few months back in 2020 itself. Now, as you can see that there is more or less parity between the three guidelines, that is ESC, ESH, NICE and ISH, in terms of the definition of hypertension, which they have still retained that any value more than 140/90 should be taken as the definition of hypertension. And they would refer to a BP between 130 to 139 systolic and 80 to 89 diastolic as a elevated or high normal blood pressure. But in contrast, the Americans, they have lowered the definition of hypertension to a level of 130/80. So for them, anything above this is hypertension. In fact, stage 1 hypertension is 130 to 139 and diastolic 80 to 89. And another difference is that there is no classification or staging of hypertension in American guidelines beyond 140/90, but the other three guidelines define further stages going up to, for example, the European guidelines go up to 180/110. So these are the differences, but fortunately for us, as I'm going to show you, there is a lot of uniformity uh, for the sake of convenience for us as clinicians is also there, and I'm going to highlight that. Next, please. And whenever we are defining hypertension, these days we do not only refer to clinic blood pressure, because there are so many other modalities to measure hypertension these days, because there are elements called white coat hypertension, masked hypertension. So just to understand how many are true hypertensives, how many are white coat hypertensives, how many are masked hypertensives, we are also measuring blood pressure at home blood pressure monitoring. Then ambulatory blood pressure monitoring, which measures both daytime and nighttime blood pressure and also gives the daily average, average blood pressure for 24 hours. So all these four guidelines have also laid down their values with regard to each of these blood pressure measurements. And again, the Americans have a slightly lower value, not that much, but a slightly lower value with regard to each of these. But the others are more or less in unison. So whenever you are resorting to HBPM or ABPM, you can, for a quick reference, look at these values. Next, please. Now, I was talking about the uniformity amongst these guidelines. Now, one thing is common is the BP goal is more or less acceptable to all the guidelines, and that level is less than 130/80. So there is uniformity across the Atlantic in that for majority of the patients, the blood pressure goal should be less than 130/80. And as far as threshold for treatment is concerned, there is also a uniformity in the fact that even the Europeans agree that those at high risk, that is a risk of 10-year ASCVD of more than 10%, even if they have a blood pressure of 130/80 or more, they should be also treated with drugs. So here is a uniformity between European and American guidelines. And regarding the goal, I've already told you. And the only other exception where the threshold is little higher is for secondary prevention of stroke. But except for this, even the threshold of treatment little bit higher for Europeans, except for the high risk population, ultimately it boils down to the same goal, that is less than 130 by 80. So that should ease the problem for us, because whenever you choose to treat a patient, at least in majority of the patients, including the elderly, except for those who are very old, very frail, or have number of comorbidities, the target should be less than 130 by 80. Next, please. And there is also a great deal of uniformity with regard to the treatment strategy. Can I have the full slide, please? Please click once more. So here you can see that first of all, the patient should be told very clearly. Uh, Next slide, please. You just click, it will come the whole slide. Yes, thank you. And click once more. Yeah. So there are 4 parts. So go on clicking till we have the full slide. Yeah, thank you. So the uniformity with regard that we should start with lifestyle modification and then institute pharmacological therapy unless the blood pressure to start with is very high. And whenever we are starting the treatment, there is also a great deal of uniformity amongst the guidelines, is that we should preferably choose a combination therapy, and that should be in the form of a single pill, either dual combination pills or triple combination pills. And another thing needs to be highlighted to all the patients, that is the treatment is meant for lifelong uh, therapy. So there is nothing called that I have reached my target, can I stop the doctor, I'm medicine doctor. No, hypertension is a lifelong disease, so the treatment also has to be maintained all throughout the life. And of course, apart from combination therapy, again for the very old or very frail patients, or BP just about in the high normal range, there we can opt for monotherapy. But other than that, the whole world agrees that it should be combination therapy and in the form of dual combination, and if that is not enough, for triple combinations. And the world also agrees that if triple combination doesn't work, we label the hypertension as resistant hypertension. There spironolactone should be the automatic fourth drug of choice if there is no contraindication. Then there are other groups of drugs like beta blockers, alpha 1 blockers, and so on, we can go on to add. Next, please. And this is the final thing I would like to show, that this is another thing, that despite the advancements in therapy, despite the advancements in communications, there is still a lot of gap between what we want to achieve in our hypertensive patient population and what we actually achieve. And the hurdles to blood pressure control are at various levels, starting from diagnosis. The screening is often not done, so proper diagnosis of a simple disease like hypertension, where we do not need very advanced gadgets, we only need a proper a validated blood pressure measuring device. And then the modality of measurement, even often the modality of measurement is also inaccurate, so you have to follow a proper procedure to to accurately measure blood pressure. Then the second hurdle is with regard to treatment, that there is a lack of protocolized approach to the entire thing. Then there is the problem with the physicians often is that there is a lot of therapeutic inertia. The private sector is unaffordable to majority of our population. The problem in the public sector or government sector is too much of patient load and drug shortages in the peripheries, in the rural areas. And the final problem is with continuity of care. So as I told you, the treatment in hypertension has to be lifelong. So we have to be very meticulous and diligent about our patient follow-up. We should provide them some kind of reminders, recall systems, and medicine should be affordable. So while prescribing, we should talk with the patient, understand what he or she can really afford, and prescribe accordingly. And finally, we have to educate the patient and his or her family so that the adherence to the treatment is lifelong. So these are the few things I wanted to highlight. And now I'll be definitely happy to participate in a discussion with Dr. Agarwal and also answer questions from all of you.
Can you take the slides out? Thank you, Dr. Soumitra, for a wonderful update and an intro to the subject. As this
Thank you.
program is seen by primary physicians as well as by healthcare providers and the general public, I would like to bring out now certain consensus issues. One is that blood pressure is a lifelong treatment. Kindly comment. Blood pressure requires lifelong management.
Absolutely. In fact, I have already highlighted that in my presentation. So one thing that should be very seriously communicated to the patient on the very first visit, that look, I will take some time to diagnose the problem in you. I'll make out whether you truly have hypertension or is it just a white coat hypertension. So I will do whatever is needed. But once I diagnose hypertension in you, then you have to accept that this treatment has to go on life throughout your life. So that is very important in some
So
form or the other. It may be lifestyle, it may be drugs, it may be both.
keep your blood pressure lower than 80 millimeter of mercury. Keep your lower blood pressure. I'm giving one number. We know there are two
Yes,
numbers, but if you attain at one
yes,
number, second will automatically be taken care of. Okay, so keep
true.
your lower blood pressure lower than 80 millimeter of mercury. Keep your bad cholesterol lower than 80 milligram percent, and keep your fasting sugar lower than 80 milligram percent. You only have to
Yeah,
remember one word, and that's 80.
that's a nice slogan. That's a very nice slogan.
So that way the number may be 70, 80, or 90, but at least you can
Yeah, I
remember
mean,
around 80.
definitely. Just to impress upon the patient that these are the general figures you have to achieve. And you have very rightly highlighted that only blood pressure control is not enough. You have to look after the other risk factors in the patient also. So you have to look after your blood sugar, blood cholesterol, your body weight, everything almost. Yeah, very important.
Now you have to see involvement of blood pressure in the organ in terms of end organ damage, and for that check your microalbumin, because if microalbumin is present, retinopathy will be involved, kidney, heart will be involved. If it is one test, then it's a microalbumin in the urine.
Definitely, fully agreed. Because microalbuminuria denotes endothelial dysfunction, and the onset of any microvascular, or since it is endothelial dysfunction, macrovascular disease also. So you are very right. It is a very cheap test, very easy to perform, and that tells you a whole host of things about the patient. Very important. I
So
fully agree.
if you want to take high blood pressure as a part of metabolic syndrome, which is evident by hyperinsulinemia and insulin resistance, which is a pro-inflammatory state and a pro-thrombotic state, metabolic syndrome. The C-reactive protein between 1 and 3 indicates mild inflammation as a pro-inflammatory state. So keep your CRP less than 1, Dr. Sumitra.
Yes, definitely. As although CRP measurements we do not perform regularly, but it is a useful tool for risk stratification. So if we are actually doing it, then keeping it below CRP, for example, in a patient with a very bad family history or multiple risk factors, it is obviously a very good tool in our hand to be used. And patient always looks for heart parameters. Doctor, why are you treating me so meticulously? What is wrong in me? So if you can demonstrate that, look, your urine albumin creatine ratio is high, your CRP is elevated. So these are very subtle indicators that you are at a high risk of developing events in future. So this, it is very useful tool to motivate the patient and to set a target for them so that they can really achieve that target. So that is how you improve adherence of the patient to lifelong treatment. Very important point.
If I have to do one dietary modification, that should be salt and low refined carbs.
If you ask me, I would say low refined carbs, because that is, as you rightly pointed, that hyperinsulinemia or central adiposity is the root cause of many problems in this country in particular, where we do not have the typical obesity, but we have a lot of central adiposity giving rise to, atherogenic dyslipidemia, giving rise to high prevalence of diabetes and also hypertension. So we as Indians take a lot of refined carbs in our diets, and that really goes on to add to our these kinds of problems of atherogenic dyslipidemia, diabetes, and hypertension. But then, having said that, salt intake, is also very high in Indian population, but that is to some extent, I would believe, is taken care of by our hot and humid weather, where all that applies to the Western population doesn't apply to us. But at the end of the day, uh, if you have controlled your body weight with restricted intake of refined carbs, salt intake will come second. But I would put refined carbs as first.
If I have to reduce my weight, reduce it by 10% to achieve 50% of the change.
If you are asking me for a, comment
Yes,
on this.
yes, 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 yes. I'm only
Yes,
issuing
sure,
the,
sure. You are giving me tips or of how to. Yeah, definitely. 10% of body weight, in fact, is a good starting point. And if you the person is not frankly obese, if you are centrally obese, then 10% will do the trick, will do the magic, and your waist hip ratio will come down, and that will reduce your risk by 50%. Dr. Agarwal is a master of slogans for the public, so I am very glad that you have said this 10% gives to. I did not catch your point to start with, but now I am fully convinced this is a very nice slogan again.
if you have to stop one thing in hypertension, stop smoking.
Definitely, definitely. I am a avid supporter of this anti-tobacco campaign in any form, not only smoking, but any tobacco in any form. And in fact, tobacco, nothing is more harmful than tobacco. If you have to control one additional risk factor, and if the patient happens to be a smoker, first of all, I in fact tell my patients, don't turn up the next time unless you have quit smoking. So I will only take care of your blood pressure and other risk factors only after you quit smoking. And I'll spend at least 10 minutes trying to convince the patient why he or she should quit smoking. Thank you. Very important point.
If your blood pressure is detected before 20 years or after 50 years for the first time, get evaluation done for a secondary cause.
Absolutely, absolutely. Because as you know, our standard teaching has been that the usual age for essential hypertension, as we call it, because there is no uh, single cause for this kind of hypertension. Of course, there is family history, but apart from primary or essential hypertension, which is the general age group is 35 to 50 or maximum 55. So, and that 35 has come down to little lower down with this information technology and the stress related to our modern day life. So anyone having hypertension onset before 30 years or maybe 25 years and having hypertension onset abruptly after 55 years should always be evaluated, first of all clinically, then of course with specific tests for secondary causes of hypertension.
If I have to choose a drug for blood pressure along with heart blockages, which one should I choose? Number one, the first drug. The first drug I
Heart
will
blockage,
choose
you mean coronary blockage or
is
conduction system blockage? Coronary.
coronary blockages.
So your choice of antihypertensive?
Yes, choice of antihypertensive in a patient with high blood pressure with
There
coronary
definitely. In fact, the one group of drugs which has shown to be very beneficial are the RAS blockers. And in fact, of the RAS blockers, ACE inhibitors have very robust trials like the HOPE trial, the Europa trial to show that definite incidence of events are reduced if we take this particular group of drugs. ARBs are a close second, although ACE inhibitors have a little age in terms of prevention of cardiovascular events over them, but the age is very thin. So ACE inhibitors and ARBs or RAS blockers are the first group of drugs we should use.
hypertension in the young with tachycardia.
Definitely, that is a problem India specific. I mean, there have been articles called adrenergic India or I mean, sympathetic. I mean, sympathetically driven Indians. So we tend to have young patients with high blood pressure. I mean, and very high heart rate. So although beta blockers have been relegated to third or fourth line in the guidelines, but beta blockers do have a place in young hypertensives in India in such kind of patients as you just mentioned.
Hypertension with obesity.
The first of all will be lifestyle modification. In fact, as you said that 10% of body weight reduction can reduce our risk by 50%. So a proper dietary advice, exercise, I mean advice should be come first. But then, as you know, therapy wise, we will go by the protocol of RAS blockers plus diuretics or RAS blockers plus CCBs. But going by if the patient has inappropriate tachycardia, again beta blockers can be used in such patients.
Two more conditions, hypertension and heart failure.
Hypertension and heart failure, there are compelling indications for two groups of drugs. And again, RAS blockers, particularly ACE inhibitors, and number two, beta blockers. So beta blockers and ACE inhibitors are a must for any patient of hypertension and heart failure. And of
Last,
course, the third drug will be MRAs, the spironolactone or eplerenone. Third
the
drug.
last one in the elderly with upper blood pressure very high, lower blood pressure normal.
Yeah, that is a problem. So, but you have to still remember our target will be to bring down to less than 40, and if the patient tolerates even to less than 130 systolic, while doing that, the blood pressure often will tend to, the diastolic will tend to come down below 70. So you will have to do it very slowly. I would persist even if it comes down to below 60, because in majority of the patients, unless you bring down the systolic, the risk factor remains. The pulse pressure going to be high, and that increases the risk. So up to 60, I would accept, but you have to proceed very cautiously and slowly.
So these were some rapid fire questions. I hope they have answered most of your, it has updated your knowledge on high blood pressure. Now we will take question answers from the viewers, but after a short break. You are watching Med Talks with Dr. K.K. Agarwal, 7 p.m. show, and we are chatting with Dr. Soumitra Kumar. I also have with me, the first question comes from Shri Anil Saini ji. Anil ji, क्या सवाल है आपका? अनिल जी, आपको अनम्यूट करना होगा.
जी नमस्कार डॉक्टर साहब.
बोलिए अनिल जी.
नमस्कार. नमस्कार
डॉक्टर साहब, नमस्कार सर. मेरा सवाल ये है कि जैसे आजकल हम देख रहे हैं यंग में बहुत बीपी की पेशेंट आ रहे हैं, हाई बीपी, तो क्या वो अपनी एक्सरसाइज या जिम में जैसे जाते हैं प्रॉपर एक्सरसाइज कर सकते हैं?
सुमित्रा जी,
डेफिनेटली जा सकते हैं.
सुमित्रा जी, इनका सवाल कोविड से रिलेटेड है. आज के दिन में जब कोविड के ऊपर में इतने रिस्ट्रिक्शंस हैं, आज के दिन में ब्लड प्रेशर का पेशेंट अगर जिम में जाना चाहे तो क्या करे?
देखिए, जिम में जाना मंजूर है, बट देखना चाहिए कि जिम कितना ओवर क्राउडिंग है, वो कोविड प्रिवेंटिव पॉलिसीज फॉलो कर रहा है कि नहीं. अगर वो ऐसा सेशंस दे रहे हैं कि बाई प्रायर बुकिंग, जहाँ पे ज्यादा ओवर क्राउडिंग नहीं है और एक पेशेंट ऑल प्रिकॉशंस लेके एक्सरसाइज कर सकते हैं, तो जाना मंजूर है. अदरवाइज द बेस्ट ऑप्शन इज डूइंग एक्सरसाइज घर में कीजिए, फ्री हैंड एक्सरसाइज, वॉकिंग, जॉगिंग ऑन योर रूफटॉप्स और योर पैसेजेस अराउंड योर होम. ये सब तो करना ही पड़ेगा, बट जिम डेफिनेटली देखना पड़ेगा कि ऑल द प्रिवेंटिव मेजर्स जो है कोविड का, वो अगर पॉसिबल है लेना तो जरूर जिम भी पॉसिबल है।
सो एक और चीज है अनिल सैनी जी जो आज की डेट में कर सकते हैं, दैट इज साइकिलिंग। साइकिलिंग में WHO के अनुसार मास्क भी नहीं चाहिए, आप अकेले चला सकते हैं, लंबी चला सकते हैं, और एक तरीके से वो नेचुरल जिम भी आपका बन गया सड़क के ऊपर में।
सर वो
Sure.
बच्चे जिद करते हैं जैसे जिम जाने की, तो मेरा ये मेन क्वेश्चन ये है, जैसे वो बीपी के
ठीक है,
पेशेंट है,
देखिए जिम के
नहीं तो
ऊपर
वो
में
अपनी एक्सरसाइज पूरी कर सकते हैं, वेट
हमारी
लिफ्टिंग वगैरह?
रिकमेंडेशन बेसिकली यही होती है कि हफ्ते में 2 दिन जिम करो, और अगर 2 दिन जिम करते हो आधा घंटे से कम में जाओ, क्योंकि आधा घंटे का मिनिमम टाइम है कॉन्टैक्ट टाइम कोविड होने का। और अगर वहां पे लोग ज्यादा हैं तो मत जाइए, बिकॉज अगर आपको, क्योंकि और आप मास्क पहन नहीं पाएंगे एक्सरसाइज करते हुए, लंबी लंबी सांस लेंगे, वायरस दूर तक जाएगा, तो तभी जाए जहाँ पे सोशल डिस्टेंसिंग मेंटेन हो, अदरवाइज नहीं। ये गीता जी हैं, गीता जी बोलिए, गीता जी अपने आप को इंट्रोड्यूस करिए।
गुड
गीता
इवनिंग
जी
सर।
आपकी आवाज।
गुड इवनिंग।
गुड इवनिंग सर। सर मेरे मम्मी पापा दोनों ही हाइपरटेंशन के पेशेंट है और बहुत यंग एज से हैं, 20 से। सर मेरे 2 क्वेश्चंस हैं, उन दोनों का हार्ट बढ़ गया है, एक का 60% वर्क करता है, एक का 56% वर्क करता है, लेकिन बीपी कंट्रोल में है क्योंकि मेडिसिन तो हमें लाइफ लॉन्ग लेनी पड़ेगी। तो सर ऐसी सिचुएशन में क्या करें, क्योंकि हार्ट बढ़ा हुआ है। और दूसरा क्वेश्चन ये है कि वो
पहले
डेली
तो
बहुत
गीता जी पहले ये समझाओ कि जैसे आपने बोला उनका हार्ट 60% काम करता है, तो कितना करना चाहिए?
सर आई एम नॉट अवेयर अबाउट दैट, मुझे नहीं पता, मुझे सिर्फ डॉक्टर्स के थ्रू ही पता चला।
देखिए देखिए जितना मुझे पता चल रहा है कि हार्ट बड़ा नहीं है, हम बोलते हैं कि लेफ्ट वेंट्रिकुलर हाइपरट्रॉफी, उसका हार्ट का जो वॉल्स है वो जो थिक हो गया है, वो एलवी मास बोलता है, टोटल मास जो है उसका मेन पंपिंग चेंबर लेफ्ट वेंट्रिकल होता है, उसका मास बढ़ गया है। और ये 60% जो बताया वो इजेक्शन फ्रैक्शन बोलते हैं, हार्ट का जो ब्लड वॉल्यूम है उसका कितना पंप करते हैं एक्चुअली। तो 60% तो बिल्कुल नॉर्मल है, 56 भी उतना खराब नहीं है। तो जितना आप बोल रहे हैं उतना खराब सिचुएशन आपका पेरेंट्स का नहीं है, बट फिर भी आप जो बोल रहे हैं वो तो देखना पड़ेगा। अगर बढ़ गया है वो साइज में तो खराब है, लेकिन आप जो बोल रहे हैं 60% 50% सुन के लग रहा है कि उनका हाइपरटेंसिव एलवीएच बोलते हैं वैसा हुआ है, और पंपिंग ठीक ही है। तो ब्लड प्रेशर अगर कंट्रोल में है तो कंट्रोल के साथ थोड़ा वॉल थिकनेस कम भी होता है, तो बोलिए उनको लगातार दवा लेने को, एंड देन उसका प्रोटेक्शन बरकरार रहेगा।
सर मेरा एक और क्वेश्चन है।
गीता जी अगर आप खूब ज्यादा एक्सरसाइज करो तो इसको क्या होगा?
सर थोड़ा मस्कुलर मास फूल जाएगा,
मसल
थोड़ा
को
swelling
बढ़
है।
जाएगा, मसल बिल्डिंग हो जाएगा।
ऐसे ही जब ब्लड प्रेशर होता है तो हार्ट को काम करना पड़ रहा है, तो हार्ट के 6 ऐप बन जाते हैं, जैसे हमारे ऐप बनते हैं, उसी को लेफ्ट वेंट्रिकुलर हाइपरट्रॉफी बोलते हैं।
सर
और
बस
अगर
एक
आप ब्लड
क्वेश्चन।
प्रेशर कंट्रोल रखोगे तो वो रिवर्स हो जाएगा। हाँ बोलिए।
सर वो डेली 5 किलोमीटर्स वॉक करते हैं, उनकी मतलब फिजिकल स्ट्रेंथ बहुत अच्छी है, तो इससे कोई नेगेटिव इफेक्ट तो नहीं है कि अगर वो वॉक कर रहे हैं और बहुत ज्यादा अपने हेल्थ पे, मतलब हेल्थ के लिए कॉन्शियस हैं, दोनों बहुत अच्छी डाइट लेते हैं?
बिल्कुल गलत कर रहे हैं, 5 नहीं 6 किलोमीटर चलना चाहिए।
6 किलोमीटर, ओके, आई विल पास
और आपका उम्र क्या हुआ गीता जी?
सर
हाउ ओल्ड आर यू?
23।
तो आप भी अपना प्रेशर, ब्लड प्रेशर नापाया क्या? यू
सर
मेजर
मेरा
किया
नॉर्मल
कभी?
रहता है। हाँ जी,
हाँ तो
एवरी डे सर।
चेक कीजिए क्योंकि फैमिली हिस्ट्री है ना। ठीक है,
हाँ
ओके।
जी, थैंक यू सर।
निदेश जी आपका क्या सवाल है? निदेश मलिक जी।
सर वेरी गुड इवनिंग।
गुड इवनिंग।
हेलो सर। हाँ सर, जस्ट आई वांट टू नो सर, वैसे आपने ऑलरेडी वो क्वेश्चन मेरा कवर कर दिया। जस्ट आई वांट टू नो सर, व्हाट इज द ड्रग ऑफ चॉइस फॉर न्यूअर हाइपरटेंसिव पेशेंट्स इफ अफोर्डेबिलिटी इज नॉट अ इशू?
ड्रग ऑफ चॉइस?
यस, फॉर
देखिए
न्यूली
ऐसा
हाँ यस सर।
हाँ, यस, सो बेसिकली इधर भी थोड़ा ग्लोबल कॉन्सेंसस है कि 3 दवा से 2 स्टार्टिंग पॉइंट होना चाहिए, एक्सेप्ट फॉर दोज जो ज्यादा एजेड है, जहाँ बहुत फ्रेल है। नहीं तो 3 ग्रुप्स है, कैल्शियम चैनल ब्लॉकर्स बोलते हैं, दूसरा है
एससीसीबी।
रैस ब्लॉकर्स, एस इनहिबिटर्स, एआरबीज, और थर्ड है डायूरेटिक। इसमें से 2, तो रैस ब्लॉकर के साथ डायूरेटिक और रैस ब्लॉकर के साथ कैल्शियम चैनल ब्लॉकर, ये फर्स्ट लाइन ड्रग होता है। अगर ये फर्स्ट लाइन डुअल कॉम्बिनेशन काम नहीं किया तो हम ट्रिपल कॉम्बिनेशन में जाते हैं, वो रैश ब्लॉकर प्लस कैल्शियम चैनल ब्लॉकर प्लस डायूरेटिक। तो ज्यादा 80% to 85% पेशेंट का इस पे कंट्रोल हो जाता है। रेस्ट जो बताया, इसके बावजूद मैक्सिमम डोज देने के बावजूद अगर कंट्रोल नहीं हुआ तो इसको रेजिस्टेंट हाइपरटेंशन बोलते हैं। तो उसका भी सेपरेट प्रोटोकॉल है, क्या देंगे इसके बाद, इसके और क्या क्या देखना है। डॉक्टर अग्रवाल ने बताया इसका कुछ परसेंटेज सेकेंडरी हाइपरटेंशन भी होता है, स्लीप एपनिया सिंड्रोम आप जानते हैं ओबेस पर्सन को। सो ये सब देखना पड़ता है कि उसमें क्या ऐसा है जिसके कारण ब्लड प्रेशर कंट्रोल नहीं हो रहा है।
नहीं सर, जैसे न्यूली जो सर जैसे मेरे को थोड़ा क्लियर नहीं हुआ सर, जो सीसीबीज हैं, यू स्टार्ट विद सीसीबीज और विद एस और एआरबीज सर, जस्ट आई वांट टू क्लियर।
नो, इट इज अप टू द फिजिशियन, जो उनको चॉइस करना है। मेरा पर्सनल चॉइस पूछेंगे तो रैश ब्लॉकर प्लस सीसीबी इज जनरली माय फर्स्ट चॉइस। ओके, अगर ब्लड प्रेशर बहुत ही बॉर्डर लाइन हो और बहुत ही बॉर्डर लाइन हो और पर्सन बहुत एजेड हो तो मैं सिंगल ड्रग से शुरू करता हूँ। और एजेड पर्सन के लिए कैल्शियम चैनल ब्लॉकर सिंगल ड्रग बहुत अच्छा है। लेकिन अगर एवरेज एज है पेशेंट, ब्लड प्रेशर 30-35 तो हम रैश ब्लॉकर प्लस डायूरेटिक और रैश ब्लॉकर प्लस सीसीबी से ही शुरू करेंगे। रैश ब्लॉकर रहेगा, उसके साथ डायूरेटिक और सीसीबी ऐसा शुरू करेंगे।
तो याद रखें जो लोग इस प्रोग्राम को देख रहे हैं, ब्लड प्रेशर को हम एक यूनिट मानते हैं कि ऊपर के 20 नीचे का 10 वो एक यूनिट कहलाता है। हम कहते हैं 1 यूनिट कम करना है कि 2 करना है, एक रफ कैलकुलेशन है। 1 यूनिट कम करने के लिए आपको 1 दवाई लगेगी। अगर 2 यूनिट कम करना है तो 2 लगेंगी, 3 यूनिट कम करना है तो 3 लग सकती है। ये रफ पब्लिक के लिए एक फार्मूला है। सुरेश जी पूछे।
नमस्कार सर।
बोलिए सुरेश जी।
मैं को एजुकेटर हूँ सर, 65 ईयर मेरी एज है सर। कल मुझे 100.7 बुखार था और हल्का खराश भी है गले में। तो क्या मेडिसिन लूं सर? घर में किसी को कोरोना नहीं है सर।
ये तो गले में खराश और बुखार तो कोविड हो गया ना, पहले तो कोविड नहीं हुआ ना आपको?
ना, कभी नहीं हुआ सर।
कोविड टेस्ट कराओ पहले, फिर कल सवेरे की क्लास में आओ। कल पहले कोविड टेस्ट कराओ। इसको इग्नोर नहीं करो। आपकी उम्र में आपका ब्लड प्रेशर, डायबिटीज कुछ है क्या आपको?
डायबिटीज है, कंट्रोल में रहती है सर। बीपी भी है।
डायबिटीज ब्लड प्रेशर के मरीज को तो इग्नोर नहीं कर सकते ना। डे 1 उनके लिए इम्पोर्टेंट है ना। अगर कोविड है, डे 3 तक निमोनिया हो गया तो लफड़ा हो जाएगा ना। तो आप हमेशा
सर यहाँ पर गुवाहाटी में मैं किसी डॉक्टर को अच्छी तरह जानता नहीं, दिल्ली आ जाऊं सर?
अरे इसके लिए दिल्ली क्यों आना आपको? कोविड के अंदर कोविड टेस्ट नहीं हो पाएगा वहां पे?
टेस्ट तो हो जाएगा सर।
बाकी आपकी कुछ डरने की जरूरत नहीं है, वहीं बैठ के ठीक होंगे आप। उसके साथ में एक और सवाल देखते हैं। अगर ये लास्ट सवाल लेते हैं हम, अगर अन्वेषा सौरभ अगर हैं तो।
मेरा नाम लेकिन हम जाएंगे। अन्वेषा का इसका आईडी से गया हुआ है ना क्या? डॉक्टर बोल रहा है कि अगर
का सवाल
अन्वेषा
इनका। सो लेट मी समराइज द होल थिंग। डॉक्टर सौमित्रा कुमार ने एक चीज बड़ी क्लियरली बोली है कि किसी भी हालत में बाय हुक और बाय क्रुक योर एम शुड बी टू कीप योर लोअर ब्लड प्रेशर लेस देन 80. Along with that, your cholesterol, fasting sugar and abdominal circumference should also be less than 80. So दिल की धड़कन, नीचे का ब्लड प्रेशर, गंदे कोलेस्ट्रॉल की मात्रा, फास्टिंग शुगर और पेट की चौड़ाई को 80 से कम रखें। और क्योंकि ये प्रोग्राम खत्म होने जा रहा है तो उसके लिए क्या करें? 80 मिनट रोज चलो, 80 मिनट एक हफ्ते में तेज चलो, कम से कम 80 कदम 1 मिनट में चलो। साल में 80 दिन धूप में बैठो, 80 साइकिल प्राणायाम की करो। दिन भर में 80 ग्राम से ज्यादा या 80 ml से ज्यादा कैलोरिक फूड एक बारी में ना लो। अगर ये सब करोगे तो हार्ट अटैक होने की संभावना कम है। हो गया तो चिंता नहीं, डॉक्टर से बात करो। वो 80 मिलीग्राम की 2 गोलियां होती हैं, एटोरवास्टैटिन एंड एस्पिरिन, मेरे को दे रहे हो क्या कि नहीं? तो उससे आपकी ब्लॉकेजेस नहीं होंगी। अगर हो भी गई तो चिंता नहीं, डॉक्टर से पूछ लेना 80% से कम है कि ज्यादा। अगर 80% से कम है तो बोलो मेरे को ट्रीटमेंट अग्रेसिवली दे दे। 80% से ज्यादा है तो कुछ इंटरवेंशन कर दे, बहुत जरूरी है। तो आप मरोगे नहीं। मर भी गए तो चिंता नहीं, कोई CSI का, कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया का मेंबर आपको मिल जाएगा, जो मरने के 10 मिनट के अंदर, अर्लियर द बेटर, कम से कम 10 मिनट तक, लॉन्गर द बेटर, 10 into 10, कम से कम 100 पर मिनट की स्पीड से अपनी छाती पीटने के बदले आपकी छाती पीट के आपको जिंदा कर देगा। और हाँ, इस वक्त में अगर आप ये प्रोग्राम देख रहे हैं और आपको लगा कि डॉक्टर सुमित्रा कुमार ने बहुत अच्छा काम किया है, तो जब तालियां बजाएंगे तो 80 से कम मत बजाइएगा, क्योंकि डॉक्टर सुमित्रा को लगेगा कि तालियां मेरे लिए बज रही हैं। एक्चुअल में आप अपने लिए बजा रहे हो, क्योंकि तालियां बजाओगे तो आपको हार्ट अटैक नहीं होगा। बजाइए तालियां डॉक्टर सुमित्रा कुमार के लिए। That's all for today. Let me thank Dr. Sumitra to be here in our function. We'll be back tomorrow 7 p.m. with another show. Stay tuned. Namaskar.
Thank you. Namaskar.